Hi, I'm David Spring with the Washington Family Rights Coalition. This is the sixth of 12 sessions presented at the FTC Workshop on July 9th, 2025. In this session, we hear from a panel of doctors and scientists on how giving kids toxic trans drugs is not supported by any credible scientific studies, and thus that nearly every claim made by the trans drug cult is based on lies and fraud. They also discuss how, in the absence of any actual science, informed consent is simply not possible. Here now is a panel of what real science says about the dangers of getting kids addicted to toxic trans drugs.
To fit in today. So let's keep going with the focus on the science. What does the science actually say about gender affirming care? Our moderator is Miles Lynch, who serves the Federal Trade Commission as one of our attorney advisors in the chairman's office.
Well, I guess it's not morning anymore, so good afternoon, everybody. I know we're running a little late right now, and you're all probably looking forward to lunch, so I won't give a long introductory spiel, but this panel is comprised of medical professionals who, building off of what we just heard from Dr. Laidlaw, can help us understand what the science really says about the benefits and the risks of gender-affirming care. First, I'd like to introduce, I'll let them get seated first. Jennifer Lal is the founder of the Center for Bioethics and Culture Network. A nonprofit organization educates the public, lawmakers, and others on bioethics issues. In this role, Lal couples years of experience as a pediatric critical care nurse and a senior level nursing manager with passion to speak on behalf of vulnerable populations. Lal's writings have appeared in various publications, including the Cambridge University Press, the San Francisco Chronicle, and the American Journal of Bioethics. Her newest book, The Detransition Diaries, was published in 2024 and co-authored by Katie Fell. She's produced 11 documentary films, 3 of which examine gender-affirming care. Her films, Transmission, What's the Rush to Reassign Gender, The Detransition Diaries, Saving Our Sisters, and The Lost Boys, Searching for Manhood, were released in June 2021, September 2022, and January 2024, respectively. She's frequently interviewed by the media and has been called upon to speak alongside lawmakers and members of the scientific community, addressing issues such as human egg and womb trafficking. Next is Michelle Cretella. She's a pediatrician, writer, researcher, educator, and speaker. She's the past executive director of the American College of Pediatricians and the current chair of its Adolescent Sexuality Committee. She serves as a pediatric spokesperson and educator for the Association of American Physicians and Surgeons and the Catholic Medical Association. Dr. Cretella serves as a peer reviewer for the Journal of American Physicians and Surgeons, Issues in Law and Medicine, and the International Journal of Behavioral and Healthcare Research. She became a leading physician critic of pediatric transgender interventions following a 2017 interview with Tucker Carlson, in which she detailed their harmful effects and called them medical child abuse. Dr. Cretella received her medical degree from the University of Connecticut School of Medicine in 1994, completed her internship and residency in pediatrics at the Connecticut Children's Medical Center in Hartford, Connecticut in 1997, completed a fellowship in college health through the University of Virginia in 1999, and practiced pediatrics with a special interest in behavioral health from 1999 through 2012. At that point, she left clinical pediatric practice to devote more time to leading the American College of Pediatricians. Lauren Schwartz is a psychiatric and psychotherapist in private practice. She is board certified by the American Board of Psychiatry and Neurology, a fellow of the American Psychiatric Association, and a senior fellow at Do No Harm. Throughout her career, she's advocated for upholding the highest standards of care in medicine and mental health. Her recent advocacy centers on gender-affirming care, particularly on interventions she believes are unsubstantiated, such as puberty blockers, cross-sex hormones, and surgical procedures for minors and vulnerable adults. Her efforts have highlighted the critical importance of high-quality medical guidelines, and she asserts that low-quality evidence should never be authoritative as to what constitutes life-saving, evidence-based care. In 2024, Dr. Schwartz co-authored an open letter to the APA regarding its gender-affirming psychiatric care textbook, garnering over 7,200 signatures, including those of clinicians, educators, and researchers. She's actively testified against legislation that she understands compromise ethical medical practice and jeopardize vulnerable patients' well-being. Most recently, Dr. Schwartz collaborated with other medical and research professionals to publish an open access review. This review compiles over 50 studies highlighting extensive health risks associated with feminizing hormones in natal males. And finally, Patrick Lappert is a plastic and reconstructive surgeon who has been in practice for over 30 years. He is board certified as a general surgeon and has served as the U.S. Navy's Chief of Plastic and Reconstructive Surgery at the Portsmouth Naval Hospital. He also served as the reconstructive surgery specialty leader for the Surgeon General of U.S. Navy. He founded the Pediatric Craniofacial Reconstructive Surgery Unit, as well as the Wound Care Center for the Portsmouth Naval Hospital, which was then the largest military hospital in the world. Dr. Lappert retired from the Navy after 24 years of service with the rank of captain. He then worked as a plastic surgeon in private practice for 18 years, recently retiring from the practice of medicine and surgery. Dr. Lappert has served as an expert witness in numerous legal cases concerning gender affirmation care in state and federal courts. He was active in the legislative process that produced Alabama's law protecting minors from affirmation care, and he has authored chapters and books about scientific evidence behind gender-affirming care, medicine, and surgery, and about the pastoral care of persons wounded by the gender affirmation industry. So if I can open up by asking Ms. Law, you have a question. Can you explain, I know we just heard a little bit from Dr. Laidlaw, what fertility preservation is?
I can actually read my remarks just so I can stay on task. Oh, sorry. Thank you, very good. Yeah, fertility preservation is an assisted reproductive technology that is offered in an attempt to hopefully maybe preserve somebody's fertility so that they can have a biologically related child in the future. There's several different methods. One is you can freeze your eggs, oocytes, you can freeze sperm, you can freeze embryos, so you actually make embryos with egg and sperm and freeze them, or often as the case of pubescent children, you can do ovarian or testicular tissue cryopreservation. And that's an option that's available just to the pre-puberty kids because they don't have egg or sperm yet. Fertility preservation was first tried and used and perfected in the field of species that are at risk of going extinct. So it was a method that was used to try to preserve different kinds of species. Then it moved into the patient population of adult cancer patients, where the therapy treatment they needed for their cancer treatment could negatively impact or harm or destroy their fertility. And then in the early 2000s, it actually moved into the pediatric cancer patient population, so that children who also, are afflicted with cancer might have the ability to someday grow up and have a biologically related child. But now we've seen it expand into the scope of gender affirmation care as something that's offered. I'm probably the only person in the room that when the Cass review came out, the first thing I did was look to see what Dr. Cass said about fertility preservation. And I was saddened and a little bit shocked that she recommended in Section 10 that all children be offered fertility counseling and preservation prior to being put on a medical pathway. And if I could just sort of put a highlight under some things that Lior said, if we move to this assessment model, if we move to this model where we can do it better, we can do a good way of treating these children, and also if we trust the experts, and who doesn't want to trust Dr. Hilary Cass, we have to be mindful of, I think, what I'm about to say, that maybe we don't want to offer this to children. As you said in my bio, I was a former pediatric critical care nurse, but for the last 20 years, I've been spending most of my energy in the whole area of fertility, infertility, and assisted reproductive technologies. I was deeply concerned as a nurse, as a filmmaker, when I learned that children who, before their puberty was blocked or before they were put on cross-sex hormones or offered surgeries, were offered fertility preservation as part of their care. And again, knowing that, the younger the child is, they're going to be offered the actual freezing cryopreservation of ovarian or testicular tissue in stage 2 to 3 Tanner stages where they have not yet developed mature gametes. It's one thing to provide the possibility of having a biological child for a cancer patient, adult or pediatric, who needs a treatment to potentially save their life. But it's a whole nother thing to offer a person who has healthy fertility, who we knowingly are going to damage, but we're going to offer them fertility preservation as part of their care. The research that Dr. Laidlaw cited on one of his slides that we published in March of 2025 in Frontiers in Endocrinology, titled "Fertility Preservation, Is There a Model for Gender Dysphoric Youth?" we found only 2 reported live births in the pediatric patient, female patient, where ovarian tissue cryopreservation was done. Only 2 of those young women that were age 9 and 13 at the time of having their tissue frozen were able to successfully have a live birth. And one other case was reported in a 14-year-old female. It did not say whether or not she had been through puberty or not, but this young girl was able to, after 4 rounds of IVF, was able to finally give birth, have a live birth. But she did deliver prematurely, which is a risk of IVF pregnancies in general, to have premature deliveries. But in each of these 3 cases, all of these patients had to have a gonadotoxic therapy to treat their cancers, for one of the reasons they were offered fertility preservation. As far as what we found in the male population, we found 0 reported success cases of young men that were offered the freezing of their testicular tissue. An important unknown for both of these categories is we do not know how many attempts were made. So of the 3 young girls that were successful in having live births, did only 3 young girls attempt this, or did 3,000? We don't know. So you have to take that stat with a grain of salt. For those that have gone through puberty, so they were offered to fertility preserve their egg and or their sperm, this is no longer seen as experimental, but all of the data that we have is all lumped together. So these young people that, as part of their gender affirmation care, offered, accepted the banking of their egg and sperm, they're lumped in with people that are struggling with infertility. They're lumped in with the Silicon Valley women who are just freezing their eggs because they want to, have their biological clock, protected. But we do know of all these data points that are lumped together that overwhelmingly, per the CDC data, that over 50% of all IVF cycles fail. And I don't know what's going to happen with the CDC data, because the group that tracks all this at the CDC was let go as part of the DOGE, letting go of people. So we're not sure if we're going to continue to track this, or if this is the end of the data that we're going to have. Embryo freezing, actually, in the CDC data, shows the highest success in live birth. And the game is to get a live birth out of all this. It's the freezing of embryos, and we know in the gender youth population, they're not freezing embryos because they're not partnered with anybody yet. They just are freezing their own egg or their own sperm. Considering the gender dysphoric population, if they want to have a child, they also just need to consider the financial cost. It costs about $1,000 a year to freeze and store and bank your eggs. So if you're an 8-year-old and you're going to be freezing and banking and storing your eggs for 2 decades, you have to look at the financial cost. And we don't know in the medical literature for egg and sperm that have been frozen for that many years, what is the success rate for any of those ending up in either a conception, a creation of an embryo, let alone a live birth. We also have to consider the fact if this is, say, for example, a trans woman, a male who froze and banked their sperm, who then grows up and is partnered with a male, there's no egg in the couple. There's no uterus in the couple. So they're going to double down on the risks and the complications of a third-party conception rate. So it's evident to me, for all these reasons, that offering fertility preservation to the gender dysphoric population is deceptive. As the chairman said in his opening remarks, this is a misleading claim. When you are being offered fertility preservation, you think that you are preserving your fertility as in having a child, when in fact you're freezing your gametes with no guarantee whatsoever that you'll get a live birth. Thank you.
Thank you for that. So, Dr. Catella, could I ask you, as a pediatrician, can you tell us your experience with gender dysphoria and gender-affirming care before it became such a big issue?
Right. I think it's important for the public to know how gender dysphoria was treated prior to the explosion in trans identities, the explosion in the diagnosis of gender dysphoria. I would say in America that the 2013 was probably that turning point. 2013 is when the Diagnostic and Statistical Manual fifth edition came out and altered the diagnosis from gender identity disorder to gender dysphoria. And one note I want to make is that no genetic or biological trait or condition explodes onto the scene. And across Western cultures, Western countries, industrialized countries, gender identities, dysphoria has grown at exponential rates. This is a sign, this rate of growth is a sign of a psychosocial condition, psychosocially constructed predominantly. We have to understand that. That's a scientific principle. So, and that's been suppressed. We've heard from Dr. Laidlaw earlier, and I think also Miriam Grossman, it's science fiction to tell parents and children and vulnerable young adults that, oh, you just have a brain that's not on the same page as your body. You have a girl brain in a boy's body or a boy brain in a girl's body. Science fiction. No one is born with gender dysphoria. Everyone is born either male or female with a sex. So that has to be clear. That concept of, oh, you're just born with the wrong brain, that is the foundational fraud right there. I have to get that out. But prior to 2013, and the best way for me to illustrate this, pediatricians almost never saw this issue. I literally had, from my training, which started in 1994 through 2012, so nearly 20 years spanning, I had one case that was very classic of a little boy. I'll just call him Andy, and this one is online, although it was censored. This family brought in their son for his 5-year well child check, and they were concerned because increasingly from age 3 to 5, he started playing more and more with girls' toys, in preschool, dressing, like a princess. And by the time he was 5, he was now saying he was a girl. At that time, again, pediatrics was not captured by gender ideology. So I referred him and the family to a family therapist, and they engaged in very traditional child play therapy. And over the course of several visits, it came out that he believed mommy and daddy loved girls better than boys. Why? Because when he was 3, after being king of the hill, he had no siblings, but at age 3, a little sister was born, and she had profound special needs. Mom and dad had to reallocate. They were all about sissy, all about sissy. So, and children, children are not little adults. From ages 3 to 5 especially, they have magical thinking. They can misperceive what's going on. And he honestly thought in one play session, Barbie's here, truck's there. Mommy, Daddy, you don't love me when I'm a boy. So once that issue was unearthed, oh my goodness, over time, within a year, they were able to change the dynamic, and yeah, he grew to know that, yeah, I am a boy and mommy and daddy do love me. Another time, and this might have been around 2007, 2008, somewhere in there, I received a call from a mother. She was going to be bringing in her twin girls, identical twin girls, for their 12-year well child check. And this mom called me up and said, Dr. Cretella, I didn't want to say this in front of the girls, but Lee, I'm just going to call them Lee and Ann, Lee refuses to wear female underwear. She will only wear boxer shorts. And I'm really, and she cuts her hair like a boy, and only wears all-boy clothing now. Do you think this is a problem? And I said, well, come in, we'll talk and see what's going on. So Lee and Ann, they were identical twin girls, but, and again, this was like their 12-year-old child check. From very early years, both girls were very active. Ann was always a girly girl, and she was hardcore ballerina. Lee, from the earliest years, she was always into rough tumble play. She was Dad's pal. She loved her dad, and now, age 12, she was totally into ice hockey. And she was never into dresses. So I reassured Mom, hey, from the beginning, these were personality differences, classic tomboy. What else is going on? How's Dad doing? Oh, we got divorced. Within the year, we had a divorce, and now Dad he wasn't physically abusive or anything like that. He had the girls every other weekend. And while I was examining Lee, but by herself, I said, hey, so I see these are your favorite clothes. Hey, tell me, why do you wear these? Just kind of gesturing to the boxers. They feel so good. They're just so comfy. All right, and she had told her mother the same thing separately. So what I ended up doing was making a referral to a family therapist to focus on, I didn't focus on Lee or her tomboy qualities, but I explained to them, I said, when families go through divorce, this is a huge adjustment, and this affects us, and I said this to them all together, the two girls and the mom. It affects everyone differently, and it can be really hard to talk about how we think and feel. We don't want to hurt Mom or Dad's feelings, but counselors who specialize in this can really help you share your feelings, and it can be really healthy. It's really healthy to do this. And then privately, I said to the mother, this clothing, the boxers in particular, I said, it's probably part fashion comfort, but, psychologically, she's probably missing her dad, and that, and the whole boy thing and haircut coinciding with the divorce, that could be some of it. And I just encouraged her, celebrate the fact that you've got a ballerina and a hockey player at home. Let her make her clothing choices and just focus on the open communication, also with her divorced husband as well, and the family therapy. Both girls thrived through high school. Today, poor Lee would have said, oh, you are gender nonconforming, which, sure, okay, she's gender nonconforming. And you're 12, wow, we really should, postpone your puberty. We want to pause your puberty, i.e. put you into a disease state. Puberty is not a disease. The absence of normal timed puberty is a disease. So she would have been put on the medical pathway so that she could have time to really decide, are you male or female or non-binary? So in the past, children had a greater chance of having their personality traits, their unique personality traits being affirmed and being shepherded through a critical developmental stage in which they could really come to embrace their true physical and personality identities, if you want to say.
So, Dr. Vitale, would you say, what would you say to a responsible pediatrician today should do in those kind of cases?
Yeah, when I'm asked by fellow pediatricians, what can we do? Because if I say these things, I'm going to be, fired, or my career will end. I will refer them to therapyfirst.org, which has wonderful resources both for clinicians and families. I will tell them, because as pediatricians, we can screen for mental health, for anxiety, depression, and underlying traumas. We call them ACEs, adverse childhood events. That is critical. As every pediatrician can screen for ACEs, for depression and anxiety. Every pediatrician can do that. And then refer for treatment for those underlying disorders. You need to know who you can trust within your local mental health area, of course. But therapyfirst.org is phenomenal, and I do send many physicians and parents there.
Thank you. Dr. Schwartz, given that we're talking about kind of mental health and all of this, as a psychiatrist, can you explain to me where you fit into the gender-affirming care funnel? Like, when are you looped into this process, and what's your role?
Sure, absolutely. Well, first, I'd like to start out with saying thank you to everyone here and for having us to be able to discuss this. And I know I only have a short period of time, so I don't want to miss being able to say, first and foremost, as a psychiatrist that is in clinical practice every single day working with patients, that from a gender-affirming perspective, repeating a medical fallacy over and over, louder and louder, doesn't all of a sudden make it true. What you've already heard today, and will continue to hear, is this is life-saving, it's medically necessary, it's evidence-based, it's widely accepted in medical and mental health arenas as safe and effective, and it absolutely is not. So as a psychiatrist, I work with patients every single day. I prioritize seeing them, doing a primary assessment. I look at the biopsychosocial model. I talk about family issues and developmental challenges. Are they going through things? Are there things in their past or their present or traumas that they've been through that have influenced things? I focus on health and wellness. We work together. I'm looking for a differential diagnosis. I look for medical reasons. Many times in psychiatry, diagnostically, I'm ruling out things that may be contributing to symptoms, whether it's depression, it's anxiety, it's distress related to gender or otherwise. We talk about all of those things. Then I talk with the patient about risk versus benefit. And I think that's where if you don't take home anything else, realize this is a very exceptionalized approach to treatment from this affirmation perspective, that all of a sudden we ignore everything else. There's diagnostic overshadowing. Don't look at anxiety, don't look at depression, focus only on distress related to gender, and then immediately funnel these patients into an extremely harmful medicalized pathway. That's not medicine. In no other area of medicine do we permanently alter healthy bodies to better align with a person's current, often underdeveloped, especially when they're kids, sense of self. Our prefrontal cortices, that front part of your brain, isn't even fully developed until your mid-20s, sometimes 25, 26, 27 years old. So to think that a child can make a decision whether or not they should go through unhindered puberty, that doesn't seem like a medical decision or a conversation I should be having with anyone, let alone a child. So when I think about what I do as a psychiatrist, and I support mental health and wellness and well-being of my patients throughout their entire lives, not just in that moment. My job is not to affirm, quote unquote, in that moment what the child thinks that they need or vulnerable young adult thinks they need. My job is to sometimes hold reality when reality is really difficult and really painful. And we have to walk through that and walk through it slowly. We don't rush to medicine. I think that's part of what has really driven this kind of just affirming model, is that we have let go of evidence. I rely as a clinical psychiatrist on evidence-based data and guidelines. My own professional association, the American Psychiatric Association, published a book, Gender Affirming Psychiatric Care in 2023. I, with several of my colleagues who are here today, we wrote a letter and said, how can you do this? This book says that puberty blockers are fully reversible, and cross-sex hormones, they're generally safe and effective, and they're life-saving, and they're necessary. And as a psychiatrist, the exceptionalized psychiatry practices get out of our way. Let us provide harmful hormones at doses we've never prescribed before in children and young adults. It leads them down a path to surgeries, and that's not medicine. It's not acceptable. No parent should have to bury their child ever. And we've heard from so many today that have gone through horrible traumas because of what medicine is doing. Medicine and mental health, we are failing patients and families. And we have to do better. And I do hope that with the help of the FTC, we can do that.
Just one quick follow-up. So you would say that you think it's aberrational how the best practices for healthcare are coming about in gender-affirming care relative to other types of healthcare? Or do you think that it's like an aberration how the best practices are being developed for gender-affirming care versus other?
Absolutely. Yes, this is, it's a remarkably, again, exceptional development of what we are calling best practices. And I think Skermeti was a wonderful example of it. If you want to read amicus briefs, read the one that the American Academy of Pediatrics that included the American Psychiatric Association, the American Medical Association, the American Association of Medical Colleges, 24 organizations. One included WPATH. They were together on an amicus brief calling this critical, medically necessary, and evidence-based care for gender dysphoria. That's false. It's a lie, but they submitted it to the Supreme Court. So yes, I consider it horrific.
And Dr. Lappert, speaking of best practices, is there a diagnostic process that you can use as a surgeon that tells you whether a patient should get gender-affirming surgery with enough confidence to get informed consent?
Yeah, thank you, and thank you to the Federal Trade Commission. I didn't imagine, 11 years ago when I started down this road that I'd ever be speaking to a federal agency about what's going on in the world of medical care in the United States. The transgender treatment industry actually operates in the American medical system through the use of deceptive labeling and deceptive practices. It presents gender affirmation care as grounded in science. It claims that gender discordance is frequently lethal if not treated with affirmation care. It claims that gender affirmation is life-saving. It claims that gender affirmation is medically necessary and that it improves the lives of self-identified children. It claims that affirmation care is founded in an accurate process of diagnosis. It claims that affirmation care is the standard of care and that all of this is based in an unassailable body of scientific evidence. All of these claims are deceptive and are made in support of medical and surgical treatments that produce severe and lifelong harms. It mislabels gender affirmation surgery as reconstructive rather than cosmetic, using that deceptive labeling to defraud public and private insurance programs, as well as defrauding the finances of families while essentially medicalizing these young people for life. Virtually all of the publications of the transgender treatment industry, from journal publications to gender clinic websites or legal declarations, refer to the WPATH standard of care as the foundational document that serves as the scientific basis for gender affirmation, including surgery. This document was produced allegedly using the Delphi consensus methodology that was spoken about earlier. But when you look into it, what you find, one of the criteria for a competently done Delphi assessment is that it's done by repeated voting processes that include members in that group outside of the organization that's doing the questioning, that the repeated questioning is happening and the voting is happening anonymously. And none of that is the case in the standards of care. All of the participants in the Delphi methodology are members of the WPATH. And we've also seen that how that Delphi process was further corrupted by the political influence exercised by the government. There is no body of evidence to demonstrate the accuracy of diagnosis. There's no long-term treatment efficacy that could support the labeling of the standard of care. They use the words standard of care is an intentional mislabeling. Standard of care suggests to us that there's a level of scientific evidence above what we call level 3 in plastic surgery that is sufficient to guide clinical decision making, and that it's called a standard of care because to do otherwise is to risk harm to the child or to the patient. There's no body of evidence to call it a standard of care. There is no body of evidence even to include gender affirmation care in a treatment guideline as an option. There isn't sufficient evidence to include it even there. The WPATH document and all the derivative documents falsely label surgeries such as chest masculinization, which is the amputation of 2 healthy breasts from a young woman. They label that as reconstructive surgery. This is patently false. Speaking as a plastic surgeon, I can tell you that this is no small distinction. Reconstructive surgery is surgery that aims at the restoration of form and function that has been lost due to trauma, surgical care of cancer, infection, or congenital or in utero deforming events. The wounded or the lost part can be objectively defined, and those findings guide the surgical planning. The restoration of form and function is the key. Gender affirmation surgery is not based in any loss of form or function. It's based in the emotional life of the patient. The motivation for surgery is emotional and subjective, and the success or failure is measured using subjective test instruments like quality of life surveys. This is the very definition of cosmetic surgery. Gender affirmation surgery is cosmetic surgery. Representing it as reconstructive surgery is an act of deceptive labeling because it suggests evidence of medical necessity where there is no evidence for such a claim. Such mislabeling is employed to mislead patients and parents and to defraud insurance. Proponents of gender affirmation care, including WPATH, make highly exaggerated claims concerning the lethality of gender dysphoria if it is not treated with affirmation care. The number typically offered is something approaching 40% mortality by suicide. There is no sufficient scientific evidence in the world literature that can be cited to support that claim. The further claim, without evidence to support it, that affirmation care, including surgery, is life-saving. That claim is used coercively, as we've heard earlier, to obtain surgical consent from parents. Gender affirmation surgery begins with a false claim concerning risk and then mislabels the surgery as having proven efficacy in saving lives. It obtains consent for surgery by the deliberate deceptive practice of the concealment of existing alternatives of care and their associated benefits. The claim of efficacy itself is based in the intentionally deceptive concealment of high-quality evidence to the contrary. For example, the most commonly performed affirmation surgery at present is chest masculinization in young women. In a 2019 scoping review of the world literature published by Dr. Tolstrup, a scoping review is level 3 evidence. It's a systematic review of the literature, in that he examined 849 papers in the world literature that examined gender affirmation chest surgery. And that's high quality evidence. That review reported that the state of the scientific support for gender affirmation breast surgery is low to very low, meaning that there's no basis for offering such surgery as a treatment option for gender discordance. To offer such surgery without offering other therapeutic options to parents and patients is an act of deception by concealment of facts that patients and parents have a right to know if they're going to give consent for surgery. The WPATH document in its chapter on surgery further deceives by suggesting that affirmation surgery is effective because such surgeries begin with a proper patient selection. That's in the first paragraph of the chapter on surgery. This is an intentional deception. The transgender treatment industry has no process or test instrument that can be employed to confirm the diagnosis of gender discord. There's no process by which the patients are selected for surgery versus not surgery. There is no testing process that stratifies either risk or benefit. There isn't even a common language of description for either the condition or its treatment, as Dr. Tolstrup demonstrated in his scoping review. There is no patient selection. The patient, typically a distressed child, makes the diagnosis. The medical team does nothing to confirm or refute or otherwise characterize the condition. On the other hand, there is a very large and consistent body of scientific evidence showing us that gender affirmation surgery is very harmful to young people. Chest masculinization surgery that we've been discussing results in the permanent loss of 2 human capacities 100% of the time. Young women lose the ability to breastfeed 100% of the time. Young women completely lose erotic sensation from the area due to the severing of the 4th intercostal nerve nearly 100% of the time. Neither the capacity for breastfeeding nor erotic sensibility can be restored. In the case of genital surgery, there is the loss of reproductive capacity as well as the degradation, if not complete loss, of erotic sensibility. In addition to those losses, there's also the additional risk of urinary blockage, urinary leakage, incontinence, the risk of fistula formation resulting in fecal leakage through the counterfeit vagina, chronic wounds, the need for repeated surgery to correct these conditions, and the markedly elevated lifetime risk of cancer caused by such chronic conditions in patients receiving high-dose sex hormones. When surgical procedures such as gender affirmation surgery are only based in low to very low quality evidence, then by definition, those surgeries must be labeled as experimental surgery. The failure to label it as such is itself an act of deceptive labeling. Furthermore, experimental surgery that involves the high likelihood of loss of function as described above can only be offered under stringent protocols that govern human experimentation. Such experimentation can never be done on children, given that it has never been proven to be life-saving. In fact, it has not even proven simple efficacy. Gender advocates will often make the claim that breast and genital surgery on gender-confused minors is rare and should therefore not be a matter of national policy. The best estimate that I can make for you at present is that over the last 15 years, approximately 4,000 minors have undergone gender affirmation surgery in America, the most common procedure being chest masculinization of young women. That number does not account for what may be a considerable number of minors who have undergone surgery in private fee-for-service clinics and whose records are privately held and therefore unreported. There's also the added problem of underestimation due to the known practice, and this was discussed earlier, the known practice of mislabeling and miscoding these surgical procedures, such as mislabeling bilateral mastectomy in a natal female and calling it gynecomastectomy, an operation commonly done in males to correct for the presence of breast glandular tissue. They justify this deceptive practice by claiming that these women are actually men. There is deception in the consent process, and this to your question, as I alluded to earlier, by misrepresenting both risk and benefit, by failing to offer alternatives of care, by using the false claim of extreme risk of suicide and obtaining consent under duress, by failing to disclose the experimental nature of the surgery and failing to provide ethical oversight in such experimentation. All of that renders consent utterly meaningless. Furthermore, the consent process overlooks the startling fact that a person suffering from suicidal ideation is by definition considered legally incompetent to give consent, or in the case of a minor, to give assent. To summarize, gender affirmation surgery is not supported by any high-quality scientific evidence. It is not based in any reliable diagnostic process. There is no test instrument that can be used to stratify risk, to select patients for surgery, or to predict the likelihood of any outcome. The harms are very evident and lifelong, whereas the benefit has not been demonstrated. It is a product that is deceptively labeled as reconstructive, when in fact these are cosmetic operations that in the case of breast and genital surgery begin with the intentional mutilation of the patient. Cosmetic operations that consistently mutilate patients are perhaps the most striking example of malpractice that I can think of. All of these deceptive practices and mislabeling, in addition to causing irreversible harm to vulnerable young people, ultimately defraud families and insurance providers for financial gain. Thank you.
Thank you, Dr. Lockwood. And thank you for all those specific examples demonstrating about how these practices ignore patient harm. Does anybody else in the panel have specific examples of gender-affirming care practices actively ignoring patient harm?
If I could jump in really quick, I think one thing that has been pointed out over and over also is that this is a model of care that's overselling benefits and remarkably underreporting harms. My colleagues and I, we published a paper about a month ago. We looked at over 50 peer-reviewed studies already available to anyone providing gender-affirming care. These practitioners, these providers are fully aware. We looked at all of the harms. This is not something that's hidden. It's peer-reviewed, it's published, it's been available. It still is. We just compiled over 50 studies that looked at harms. And this is just in one area of estrogen used in natal males. Please understand that they are asking us to ignore harms. They're asking patients and parents to ignore horrible outcomes at the expense of children's lives.
I think just to tag on that, the same thing is in the paper that Dr. Laidlaw and Dr. Thompson and I published. The data's there. I mean, we just went looking for it. You know, we found that there was 0 young men that were offered, you know, testicular cryopreservation that went on and had a child. So it's not like we discovered something that was, you know, new or novel. And I think I will just underscore the fact that I don't want us to take the CAS review and just remember that one little point where she recommends this. And I think it's because she's unaware of the data, which is out there. Thank you.
Thank you both. And obviously this event is focused on gender-affirming care for minors. I was wondering if anybody could weigh in on what exactly makes it different for minors than it would for a gender-dysphoric adult. Like, is there anything particularly about children, the vulnerabilities that they have, that make this especially problematic?
You know, I think it's their vulnerability. Their vulnerabilities, that's why minors, our laws normally protect minors, because children are not little adults. Adults have higher cognitive development and function, have lived a longer lives, have had greater experiences, can better assess risk and benefit. Even adults, of course, cannot offer informed consent if they're being fed lies, right? So whereas we are focused here on protecting minors and being more maybe paternalistic, because we recognize that children and adolescents have underdeveloped judgment centers of their brain and have lived shorter lives, every adult requires and has a right to the true facts in order to give informed consent. And I think, you know, those of us who have spoken and will speak, we are often, you know, defamed and, oh, why should we believe you versus the AMA, the AAP? And I think it comes down to 3 things: follow the science, follow the money, and follow your heart. Science proved long ago that sex is determined by genes alone, and there are only 2. No one is born in the wrong body. What we are dealing with in this population of minors who are seeking so-called gender-affirming care, science has also revealed they are the most vulnerable of the vulnerable. We're dealing with children who have an average, one study found an average of 5 traumas in their childhood. They have untreated psychiatric disease. They may be on the autism spectrum. They may have ADHD. Many are experiencing LGB attractions. So that's follow the science. It's a vulnerable population. Follow the money. AMA, AAP, ACOG, APAs, they are heavily funded by Big Pharma. This is a cash cow for Big Pharma and for all those Big Pharma funds. Those of us who speak today, we're not getting paid to be here. Right. It's quite the opposite. We put our reputations and our livelihoods on the line. Follow your hearts. You got to ask yourselves, is it loving for big medicine to offer your daughter, your sister, your LGB child, your ADHD child, mutilation, castration, diseasing, and sterilization? Is that loving? I call it criminal. My profession used to call it eugenics. That's where we are, and that's what we have to get out.
Jennifer, do you want to give one last